When do creams work for basal cell or squamous cell skin cancers? What are the side effects of these creams?
In general, I mean, I tend to think of creams as being really useful for precancers, and maybe the least invasive of any of the types of skin cancers, particularly superficial basal cell carcinoma. Um, yeah, you can you can approach them that way. I think um, in general, I'm happier removing a skin cancer. There are situations where people may have multiple cancers, multiple non-aggressive ones, or multiple superficial basal cell carcinomas, where we might treat with a topical agent. And the same with precancerous lesions, like actinic keratosis. Some may consider the most superficial precursor to a squamous cell carcinoma. Yeah, I think they in both situations it's useful. It might be useful to consider creams or topicals when you are treating a field and looking for a field effect rather than a discrete lesion. In terms of side effects, there is no treatment without a side effect. When you treat with any agent for these, you're going to get an inflammatory response. There's going to be redness. There'll be some ulceration, and a rather protracted course. If you're going to treat a basal cell superficially with a topical agent, you're looking at a several month course of treatment. When we're treating the actinic keratoses, you're looking at a several week course of treatment in general.
How do I know that my surgeon is using the best procedure to minimize scarring?
So the best procedure is going to vary with what we're taking care of. It varies with the cancer. These are lesion specific. Certain lesions are amenable to treatment by Mohs micrographic surgery. And Mohs surgery is a technique whereby the tumor is removed in a way that allows specific processing that enables us to see and delineate the entire surgical margin. That is tremendously advantageous. That allows us to see 100% of the surgical margin rather than the 1 to 2 or 3% that we might see with standard bread loaf pathology. One of the real benefits there is that it's very direct. As we mark and map every section, I am able to see, or the Mohs surgeon is able to identify areas of positivity with great precision. Then we're able to remove them with equally great precision. And all of that boils down to a smaller margin initially with removal of the cancer and potentially a smaller defect. Another real advantage comes at time of reconstruction. When I'm looking at a defect from a Mohs procedure, I know that 100% of the surgical margin has been vetted and that it's completely clear. Knowing that it's completely clear, I'm free to move skin around any way I need to, make incisions to move things around in such a way as to provide the optimal functional and cosmetic result.
What are the guiding principles for reconstruction after a skin cancer is removed?
Sure. From my own perspective, when I'm dealing with a defect after a Mohs or after a conventional excision, what I'm doing is, first and foremost, there's our paradigm is tumor clearance first, recapitulation of function, recapitulation of cosmesis. Once we've achieved the tumor-free plane, we can address function and cosmesis. Frequently I'm working in areas around the eyelid or on the nose or on the mouth where function is paramount. We want to make sure that we want to make sure that the mouth, the nose, the eyelid, etc., are all functioning optimally. We also take great care to address cosmesis. People after they have a cancer removed want to look the same. They want to feel the same. When I'm looking at a defect, once I've taken care of function, I'm looking at things like free margins. I want to leave free margins as they were previously or restore them. I want to have incisions that are made strategically at borders of cosmetic units. When I'm doing that, I'm almost thinking about as if I'm a tailor. If I was going to alter something, I would actually make I'd make my cuts where this, on a seam. So when I sew things back together, I'm sewing back on a seam. We approach that similarly. We look very hard at contour. Contour is really important when it comes to reconstruction. And oftentimes the shortest incision doesn't give the best cosmetic result. Maybe a more lengthy incision that allows skin to be moved and soft tissue to be draped and to restore contour. And when we restore contour and utilize the cosmetic unit principle, we're able to restore the shape of the face and able to um, have a reconstructive result that stands up to multiple views and looks good regardless of light and shadow.
Are there any tricks for wound care after skin cancer surgery? For example, minimizing the scar and discoloration.
So, in terms of managing scars, managing discoloration, I think it's important to remember everybody heals differently, but we can optimize results for everyone that we take care of. First things first, always during surgery, meticulous technique, good hemostasis, excellent apposition of with your deep sutures, and careful placement of your superficial sutures are all technical things that we all do every day to try to optimize on that end. And of course, prior to that, talked a little earlier about planning the repair. The planning is really the most important thing. It's where you place the incision that really, really counts, as much, if not more, than the technical surgery. But you want to optimize both. Immediately post-procedurally, I think you want to instruct your patients to take it easy, to avoid activities that would result in a shear stress on the wound or a hematoma beneath it. Do everything to minimize infection. If a patient notes a wound infection, if you get a call about warmth, redness, or swelling, evaluate the patient. If there's a wound infection, culture treated appropriately. All those things actually translate to an optimal result. When I see somebody at suture removal, assess the wound. We usually apply steri strips. I tell patients it's kind of chicken soup for me, a little extra support for a few days. Afterwards, after the steri strips fall off, there are any number of products that they can apply topically. I say they're free to use them if they want to. I think it's really important that they apply sunscreen in general, but sunscreen to the area of the incision. You don't want to burn or tan a fresh surgical incision because then you might actually have discoloration. If there is discoloration at the wound in patients with certain skin types or certain complexions may be more predisposed to developing darker or lighter color at the wound. If it's a darker color at the site, there are topicals that can be applied to try to lighten that or to bleach that away. Longstanding hypopigmentation or a light area is harder to manage.
What are your thoughts on the use of home remedies for skin cancers?
I've heard about people putting things on like bloodroot, for example, which really is essentially a zinc chloride, which was used as a tissue fixative back in the day before they did, when they did fixed tissue Mohs procedures. Something like that will actually cause an ulcer in the area. So what they're doing is performing home destruction. I haven't encountered anybody, honestly, that's putting, lemon juice or orange juice on things. I mean, I don't put any stock into that. I don't think it should work. Um, I basically will try to reinforce with anyone, I think it's good that you're aware of yourself and you're aware of an issue on your body, just have it evaluated by a physician rather than trying to deal with it at home. If it turns out to be nothing, that's great. And if it turns out to be something, we can take care of it and take care of it effectively and safely.
What is the benefit of massage post-surgically?
So, I think post procedurally, if there's swelling in an area, I think gentle massage is something we frequently recommend. Depending on what we're trying to take care of, especially if it's swelling in an area where there may be some lymphatic rerouting that needs to happen. Pretty common, for example, like around the eyelid. Lower eyelid is an area that likes to swell post surgically. And I think it's very reasonable to have a patient perform massage gently for a few minutes at night before bedtime. I think if you truly have a hypertrophic scar, something looks raised, I think massage will help to a degree. You may have to do a little bit more than that. There may be silicone sheets that need to be applied. You may, your physician might want to inject with with an intralesional steroid. It all depends on what we're trying to treat with the massage. But in general, yeah, I think massage is actually a reasonable thing to do post-surgically.
When are basal cell or squamous cell skin cancers considered serious? How are these managed?
So it's a great question. So serious is kind of in the eye of the beholder. I guess I take every patient seriously, every tumor seriously. I guess I look at them from the prism of risk, right? What's my high risk and what are my lower risk? And you're asking basically what is a higher risk squamous cell or a higher risk basal cell? A higher risk basal cell is one to me, to my eye, is one that maybe larger than a centimeter or two, maybe a wrist location, maybe sitting on the eyelid, sitting on the ale of the nose, sitting on the cutaneous lip. Also, when histologically that may be more aggressive, may have an infiltrative subtype. In terms of squamous cell carcinomas, higher risks are larger tumors, tumors that are larger than a centimeter, tumors that show poor histologic differentiation, tumors that show perineural invasion, tumors that deeply invade, beyond the leg. We have a staging system for squamous cell carcinomas, and really good staging system for that. Actually, two good staging systems: the AJCC 8 and the Brigham and Women's BWH. And when we stage those larger, more aggressive tumors in either stage, they may skew toward the 2B or the T3 stage. So in those cases, we may consider preoperative imaging as necessary. We will certainly aggressively surgically treat them and also evaluate them for occult perineural disease. If we see occult perineural disease, despite clear margins, that might actually be a call for adjunctive treatment, which might involve usually postoperative radiation. If we find anything on our imaging, if we have any disease in lymph nodes, then we think about other adjunctive treatment. Today our go-to is more immunotherapy than chemotherapy, and I'm not going to talk about the immunotherapy. I think I will defer to Dr. Pavlick for that.
So, essentially, what do I consider high risk squamous cell or basal cell? And essentially, as a medical oncologist, anybody who walks in my door or gets referred to me is going to be considered high risk or locally advanced or metastatic. So depending upon how these patients present, depending upon do they have localized lymph node disease that is just too bulky to be resected without cosmetic impact, these patients are referred for what we call neoadjuvant treatment or treatment before a surgical resection. If they have metastatic disease, these are also patients who come in to see me as well. Many times patients will be resected and referred by head and neck surgeons for head and neck squamous cell carcinomas of the skin with the question of, do they need postoperative radiation? And again, to echo John's comment, these are patients that have extensive perineural invasion, and we have clinical trials that are now exploring the benefit of postoperative radiation with or without immunotherapy. So patients can be enrolled into a clinical trial. So we will actually find out, does immunotherapy help improve the outcome when added to post-op radiation for these high-risk patients? If patients have metastatic disease that is not resectable, then we speak to them about immunotherapy, since about 50% of patients with locally advanced or metastatic basal cell, metastatic squamous cell will respond to immunotherapy. So that's usually our first line of therapy. Since chemotherapy can be used, we usually use it as a second line, since many patients who are treated with immunotherapy will go on to respond. And many times those responses are long lived, as opposed to chemotherapy, where we treat patients and they'll have a response, but it may not be long lived. When it comes to basal cell carcinoma, these are tumors that we commonly start with targeted therapy, namely a hedgehog inhibitor, since these tumors respond very quickly to this type of therapy. But if they then progress, there is data, and the study has now been completed, looking at using immunotherapy for these patients who fail or cannot tolerate hedgehog inhibitors. There will also be a study looking at patients with metastatic basal cell cancer, to see if in fact immunotherapy is a viable option for them.
When do patients with locally advanced skin cancer get referred to medical oncology?
Sure, I could start there because I think that is definitely case by case. Um, and I like to think, yeah, I like to think about it in terms of when is it most appropriate to refer to med onc rather than what is operable, what is inoperable, because inoperable is a very moving target. And for example, um, there may be somebody who's not a surgical candidate for whatever reason, and maybe a tremendous number of comorbidities. Surgery may be considered too high risk, or in some cases, the tumor, may be too far gone to practically approach surgically. And in those instances, it may be in the patient's best interest to approach it from a med onc perspective, especially now that we've got some agents that actually really work. And actually we see some responses. Thinking in generalities, a good example might be a periorbital tumor, for example. Tumors that invade the orbit are notoriously high morbidity and, in some cases, even high mortality. There have been series of, there's one large series of patients where there's about 50 cases, I believe, of periorbital basal cell carcinoma, where 3 recurred even after orbital exoneration, which is an extensively morbid procedure. I think in situations like that, a referral in med onc can be especially useful, especially considering that we can get responses with what we have available to us now.
So again, surgeons, dermatologists will refer patients to medical oncology for reasons that essentially John outlined. They don't have to be considered unresectable. It just may be that the patients may not want surgery. They may not be able to tolerate surgery. They may have comorbidities that preclude them from going through surgery. Or they have distant disease, and those are patients that would benefit from a systemic type of therapy, which is essentially what I would provide them with.
Please tell us about the drugs that are used to treat advanced squamous cell and basal cell skin cancers.
Well, we can start with the drugs that we use to treat advanced squamous cell carcinoma with, and they are essentially the PD-1 inhibitor drugs. These are immunotherapy agents that are infused intravenously, either every 3 weeks or every 6 weeks. There are currently 2 drugs that are approved for advanced squamous cell cancer. One is called cemiplimab, the other one is called pembrolizumab. They both show approximately a 50% response rate. And again, with those responses, many of those responses are in fact durable, which means that if you can get the cancer to regress, it usually translates into long-term benefit for that patient. those are our frontline therapies. If they don't work, there are other treatments that we can offer patients. We can offer them chemotherapy with squamous cell carcinoma. Some of these agents will also respond to EGFR receptor inhibitors like cetuximab. Sometimes when these patients are undergoing radiation therapy as well, because the lesion is large, we may add cetuximab to the radiation for these patients. When it comes to basal cell carcinoma, that is locally advanced or metastatic, our first line agent is what's called a hedgehog inhibitor. This is a targeted therapy. It is a pill. It's a pill that patients would take once a day. Um, and it's very effective against locally advanced or metastatic basal cell. It does, however, have some side effects like hair loss, uh, loss of appetite, loss of taste, and muscle cramps, which sometimes makes it very difficult for older patients to be able to tolerate this drug for an extended period of time. There is currently data that's looking at the use of immunotherapy. One of the agents that's being looked at currently is the medicine called cemiplimab, to see if cemiplimab would benefit patients with locally advanced or basal cell carcinoma if the patient doesn't tolerate or has progression while taking a hedgehog inhibitor. So those are really our cadre of agents that we use for those two diseases.
Could you please go over the side effects of immunotherapeutic agents used for squamous cell and basal cell skin cancers?
Sure. I think when we talk about immunotherapy, particularly the PD-1 agents, have a profile of side effects. However, the number of patients who actually get those side effects is very small. The most common that we see is itching and rash. You can have a rash that's not itchy. You can have a rash that is itchy, or you can be itchy and not have a rash, which is usually what makes patients most disturbed, because they'll call and say, I'm itching, but I really don't have a rash. But we know how to manage those. Um, some patients may get other inflammatory symptoms because remember, these are pro-inflammatory agents. So we're revving up the patient's immune system, and I tell them that they can get a flare of their arthritis, especially if they're older. They can get what's called pneumonitis, an inflammation of their lungs, colitis, and inflammation of their colon, which would lead to diarrhea. But these agents are metabolized through the liver and the kidneys, and so we would need to assess those organs every time we infuse the drug, making sure that the liver and the kidneys are working effectively so it's safe to give these patients medication. There are all of those agents, all of those side effects that I just discussed are side effects that are reversible, essentially. However, there are what we call the endocrinopathies, or the impact on endocrine producing or hormone producing organs, that most of the time, I'm going to say greater than 95% of the time, if they occur, they are going to be a lifelong issue that needs to be dealt with. The most common is hypothyroidism. The immune system can essentially attack the thyroid gland, causing patients to become hypothyroid. If in fact that happens, we know this because we can monitor patients' thyroid levels every time they come in for infusions. We would have to give them thyroid supplements, which essentially last their entire lifetime. It's exceedingly rare that this reverts back to normal, but in rare cases it can. But I usually tell patients, if I cause damage to one of your hormone producing organs, you're essentially going to commit yourself to taking replacement hormones for the rest of your life. So that patient would then take a thyroid pill every day, forever. The other organ, and that happens roughly about 10% of the time. The other hormone producing organ that can be affected is the adrenal glands. The adrenal glands will make a person's stress hormones. And if those get affected, how often does that happen? Well, less than 2% of the time, but it's still not zero. We would have to replace those steroid hormones with something called hydrocortisone. One of the other potential side effects of immunotherapy is hypophysitis. Well, hypophysitis is essentially an inflammation of the pituitary gland that sits in what's called the sella turcica. It's a portion of bone that is shaped like a horse's saddle, and you have this gland that sits inside that saddle, and if it were to swell, it causes pain. Well, the sella turcica and the pituitary gland sit right between your eyes. So if in fact this starts to swell, patients will call and say, I have a terrible, terrible headache. It's in the front of my head and it's positioned right between my eyes. And that's essentially your diagnosis right there, that the patient has hypophysitis as a consequence of immunotherapy. When patients get hypophysitis, they may or may not have resulting long-term endocrinopathies, such as hypothyroidism and adrenal insufficiency, because the pituitary gland secretes the signals that make those glands secrete those hormones. So it's a very, again, very rare thing that can happen. But when you get that phone call, you have to think hypophysitis when you've got a headache right between the eyes in an immunotherapy patient. And finally, the last endocrine organ or hormone producing organ that can be affected is the pancreas gland. It is exceedingly, exceedingly rare for this to happen. How rare? Well, less than 0.2%. However, if it does happen, patients would then be rendered insulin requiring diabetics. And so that's very important to tell patients, because they need to understand that if they are that rare person that this happens to, they are going to be committed to giving themselves insulin to control their diabetes for the rest of their life. So that's really the immune side effects in a nutshell. They are very rare, but I do make it a point to tell all patients what those potential side effects are, just so they're aware and are fully informed before they proceed with any type of therapy.
Could you please go over the side effects of hedgehog inhibitors for advanced basal cell skin cancer?
We then talk about the hedgehog inhibitors, or the pills that we use to treat basal cell cancer. And I touched a little bit briefly on what those side effects are. And it really is hair loss, taste changes, weight loss, and muscle cramps. And again, they're not horrible, but when you think about the patient population that you're going to be treating, if you have an elderly patient who's on the frail side and you take away their taste, well, they just don't want to eat. And so they become more frail. So it really is a balancing act between what's the best agent to treat their cancers with, and when are you going to hurt the patient. And so it really is a patient by patient decision about what is the best way to manage these cancers.
What can a patient do to prevent skin cancer from coming back? Are there medicines that can be taken, or is it just a matter of sun protection?
So that is a fantastic question. Patients always ask, am I going, is this going to come back? And there are different definitions of that, because we remove a skin cancer, especially we remove one by a Mohs procedure. If it's a primary skin cancer, I can tell them that, gee, there's up to, a 99% chance that this one's not going to come back, but it doesn't mean that you're not going to get a skin cancer someplace else. Somebody who's had one skin cancer, may have, as much as a 50% chance of getting another one somewhere. So what can they do? a lot of these things, I say are like compound interest, from sunburns we got a long time ago, but we still tell people they need to protect from the sun. Sun protection is really important. We can at least prevent the number of actinic keratoses and probably some of the squamous cell carcinomas as well. I think it's very key that they apply their sunscreen every 2 hours and apply enough of it. When they're out, they also wear hats, wear sunglasses, protect themselves as much as possible. There is some evidence about niacinamide for non-melanoma skin cancers. People, you can get it in the drugstore, they can take it over they get it over the counter. But I think really the most important thing they can do is sun protect. And if they are at risk for developing numerous skin cancers, it's important that they see their dermatologist for screenings.
Yeah, I don't have a whole lot to add. The most important thing is really sun protection. Unfortunately, most of these skin cancers really is a result of cumulative sun toxicity over the course of someone's life, but that doesn't mean that you shouldn't continue to use sunscreen and try to prevent new things from happening. As people live longer, there is an increased risk of them getting more skin cancers because they are living longer. And so there really is no magic preventive medicine that's out there. It really is sun protective clothing, sunscreen. Don't forget the sunglasses because we always want to make sure that people protect their eyes as well. But it's all about prevention.